I'm very happy to introduce Dr. Tom Reichenbacher today. He's going to speak on an important topic, the treatment compliance. Again, we can't really do much unless the patient is coming for treatment. And I think most probably all of you know that only maybe 35% of the kids who need mental health, they get treatment. And out of that 35%, I'm not sure how many are compliant. So hopefully we will get some, suggestions from Tom's talk, what we can do to, improve the compliance. Just to say a few words about Tom's background. Tom, he did his bachelor's from University of Arizona, then he went to medical school in Arizona. Then he did a public psychiatry fellowship for a year here. And then for general psychiatry residency, he went to Ohio State. And he did child psychiatry in Boston University. He was chief resident there. He's board certified in adult and child psychiatry. And before he came here, he was in Albuquerque, then he was in New Zealand for a year or so. Then he decided that he wanted to come back to Arizona. He has been involved with, number of activities, clinical activities, and also he has been an important faculty member. He takes his duties as a faculty very seriously, and always, knows what's happening, the recent research, and publications. He has, had presented a number of places locally and also in the annual psychopharmacology conference, and has published some papers. So he has no financial disclosures. So thank you for doing this, Tom. Okay.
Well, thank you, Hari. Can everyone hear me now? Yeah, okay. Well, I wanted to start the talk discussing something I heard on NPR in October. I heard a discussion that I hear almost on a daily basis when we talk with our parents and families. This is on NPR's Talk in the Nation program. They're interviewing a mother, also an author, journalist, talking about a book that she had about her son and difficulties, and what I talk about the angst of diagnosis and treatment for mental disorder, particularly ADHD. She went on, this is a small excerpt from her discussion. She described how she had stronger reservations, she and her husband, about the diagnosis and treatment, particularly treatment with medication for her son. But went on to say once they decided to do this, they decided to do it for 1 year to get them through some crisis in the family. And she described having some dramatic effects, dramatic benefits of medication for ADHD. But then she went on to describe side effects and problems, concerns, particularly with side effects with sleep. So she went on to say something I thought was quite striking, that people usually stay on this medicine for only 13 months, which is probably true, which is greatly concerning of a disorder that lasts for many years, most of the child's lifetime, childhood and into adolescence and often into adulthood. But the average is probably 13 months that a child stays on medication for ADHD. What's interesting about this person, when they decided, this mother was deciding, she also was diagnosed with ADHD, but she also had some issues about continuing treatment for her own child. And this is something we deal with on a very, very common basis, about compliance and continuing treatment, staying involved in treatment, and a number of different disorders. I'll discuss, most of my talk will be, most of the literature is on treatment of ADHD, which is the most common disorder we see in kids, but it covers almost all the other disorders, and I'll go through some of those issues as well. And of course, if there's any questions or comments, certainly speak up and ask me some questions. I want to talk briefly about the scope of the problem, which I think we all know, and some causative factors. There may be more, but I'm going to discuss most of what I've seen in the literature and also with their own work, and also some discussion about strategies for improvement. So the scope of the problem is really quite large, and as I said, it covers pretty much all disorders. As I said, most of the discussions have been, or the studies have been on treatment for ADHD, but also medication for depression, bipolar disorder, anxiety disorders. The adherence rate is really quite low. Some studies show that this one study, for instance, in a long-term study of ADHD, 52% of the kids' families were adherent after 3 years. And also, when you get into even more details about it, this is a very interesting study that finding out of the MTA study, that very large multi-site study of treatment for ADHD with a number of different strategies with both different types of therapies as well as medication. And when they found that even when kids and parents verbally reported compliance, at some time during the treatment, 46% of the kids were not compliant when they tested the saliva for assessment of saliva for the stimulant medication. So even when the person is saying they're compliant, they aren't often enough. So it really does cause some problems in terms of how you treat these kids and how you assess their compliance as well. Also in terms of therapy, there are very low rates of compliance with other disorders, particularly I see studies about anorexia, substance abuse, depression, anxiety disorders. Also in psychotherapy, the compliance is often quite low. And this also brings up issues that in terms of compliance during even clinical studies, there's quite a low adherence rate or a very high dropout rate, which makes our studies maybe be less valid, and it may not be as informative if all the participants were staying in the study and completing the treatment. There could the causative factors. I want to go into depth with these, and these are what I've been seeing, and I've lumped them into several large groups. I call them socioeconomic factors, child and youth factors, parent factors, and then the big one, stigma. And I believe that that's an equally important issue, especially to talk about now after the events of last month in Tucson. These factors may kind of overlap in some ways. And I'm going to discuss most of them. I'm sure there may be more that I'm not discussing, but in terms of socioeconomic factors, it seems like insurance coverage, mental health parity still has a strong effect. There still is, even though we have the Mental Health Parity Act, I believe 2 years ago, there's still a number of our parents that can't afford the treatment. They may have a very high copay or deductible, various other factors. It keeps them from staying involved in mental health care. Other factors I've seen, which is interesting, some of the basic socioeconomic factors. Transportation, there's a very big shortage of child psychiatrists and child mental health workers around the country, so it may be a long distance to get treatment. And one study found that if a child or family had to travel more than 30 miles, they had a much lower adherence rate. Also, socioeconomic factors that, in terms of the mobility of families, poverty, other issues. There's one study that found that they were trying to follow kids' compliance and adherence rate out of LA County, and found that of 56% of the people that they tried to contact, they couldn't contact because their phones are disconnected, they moved, they didn't have updated information about how to get a hold of people. And that seems to involve both poverty, the mobility of our population, and it suggests that often the most needy families, the most needing of our treatment, are often the ones that aren't getting the treatment because of these other issues and how that may be hard in terms of transportation, getting to appointments, other factors that keep them from being involved in treatment. Can anyone think of other factors in terms of what I describe as socioeconomic? Something I'm missing? And these might overlap quite a bit with parental factors in terms of poverty issues. Also in terms of child and youth factors, and these are quite big too. Often it's a number of factors, age, gender, disorder. Age, for instance, older kids, teenagers have a much higher, there's such much lower adherence or much higher dropout rate. And this is a big issue, particularly in terms of long-term disorders like ADHD. Often kids, especially when they turn 18, they often stop being involved or coming for treatment, or when they become at the age of consent, they drop out of treatment, which is a big factor in terms of how to continue treatment and transition from adolescent into adulthood. It can be a big issue. So younger kids tend to have better compliance, maybe because the parents are able to involve them and keep them involved in treatment. Gender also seems to be an issue, particularly in studies. One study on bipolar disorder, in the males had a much lower adherence rate than the females. This may be true of other disorders as well. And also the disorder itself, particularly in the externalizing disorders where kids don't see the problem, it's other people's problems, particularly with oppositional defiant disorder. One study showed that when a child with ADHD and had a comorbid oppositional defiant disorder had a much higher dropout rate or lack of compliance. And interestingly, they also found that kids with ADHD and ODD, the ODD kids would have much more complaints about medication side effects, even though when they did objective studies, those kids didn't have any more objectified, validated symptoms of side effects, but they complain about side effects more often. And then also disorder severity. I've seen a lot of different studies showing that dropout rates can be affected by the severity of the disorder. And it can go either way. For instance, kids with less severe ADHD tend to have lower compliance, almost as if they can tolerate, or the family can tolerate some of the behaviors, and therefore it didn't cause as much impairment. But on the other hand, of course, we know that use with substance abuse, the more severely substance abusing kids will have lower compliance, and maybe some other disorders too, particularly maybe anorexia. The kids with more severe anorexia may have higher dropout rates as well. Can anyone else think of other youth factors that may be involved? So most of them are that I can see in what I've put up out of the literature. And then the bigger one is parental factors, and as I said, the first one, poverty, family dysfunction, may also be overlapping with socioeconomic factors. And it's kind of hard to put a number of exact detail about what we mean by family dysfunction, but how well the family is functioning in terms of their daily routine. Educational level seems to be noticed with low education level parents have higher dropout rates. Parents who became parents as teenagers have higher dropout rates. Other factors that maybe distract the parents from bringing the child for treatment, such as child care, work schedules. It's hard, again, to put a number on that, but those are certain factors that we see on a very, very frequent basis. Gender as well. Unfortunately, men, fathers are less compliant and have less ability or not as apt to identify a disorder in their kids than the mothers. And the big one that we deal with, and that's been reported often in the literature, is parental mental illness. We've known for many years that particularly parents with ADHD have much higher dropout rates than non-ADHD parents, particularly for the treatment for the kids that have ADHD. That can be a couple of reasons. I mean, the obvious one is that parents just forget appointments, they're not organized well enough to get to appointments on time, etc. But it may be some other more psychodynamic issues of the parents having issues about treating their child for a disorder that they didn't get treatment for, or projecting onto the child, I have ADHD, they have ADHD, they don't really need treatment, etc. But it does seem to have a higher dropout rate than other parents. Also, many studies show that parents with depression, particularly mothers with depression, have much higher dropout rates than non-depressed parents. And also in terms of parents that have had psychiatric hospitalization, particularly during a course of treatment, if a parent has psychiatric hospitalization, they have much higher dropout rates as well. So I think we have to be aware of other mental illness in the family, particularly the parents. Yeah, Francisco.
In adults, dealing with adults, people with OCD are very, very notorious, in my experience, for being very uncomfortable with the use of medication. And they worry a lot about the diet of their children, their formula they'll be using, and of course medication their kids may be exposed to, vitamins, vaccines, and a number of those issues. So I wonder if OCD in parents is something that also predicts affinity for non-pharmacological interventions or aversion for compliance.
That's a good point about anxiety or OCD in parents, and I haven't seen a lot, but I've seen that in a personal experience of parents that may be more in tune to, because of anxiety disorders, in tune to possible side effects or worries or concerns. I've had one parent that had fear of germs, and she wouldn't take her kid here to this clinic because of the hospital and having to walk by ill people or sick people. And I think that's something to be aware of. That's a good point. Any others that people have seen? Yeah, Peter.
I have a point. I think subtly, like some of the parents might have similar problems that the kids have, because they run families. There's a level of denial if there actually is a problem, maybe. So like it's normalized, maybe like, oh well, he's not doing that bad. You kind of not be able to see it in a way.
Yeah, that's a good point in terms of denial about if the child has a similar disorder. And I think that's what happens often for the ADHD parents. They have a similar disorder. They have a hard time identifying their own ADHD, and therefore my child isn't that bad. He's kind of like me. I did okay. I got through school or whatever, and therefore my child doesn't need treatment either. That's a good point. But also in terms of parents, I think we also have to be aware of some other major issues about fears, or what parents have heard about mental illness, about disorders, certainly about treatment and medication. Because every parent has heard horror stories about Ritalin and medicines such as that. I mean, if parents go on the internet, they'll see quite a few scary things like this. One you can see, RitalinDeath.com. Not a pleasant thing to see, and see a number of concerns, myths, maybe about medicine, particularly ADHD, but other medicines too. And I think also in terms of family perceptions, I want to talk about that also in the next causative factors of what parents see, the whole family. They'll get influences or maybe advice from other parents or friends, in-laws, grandparents, that has strong effects on parents' compliance and also acceptance of mental illness. And I think we really have to acknowledge those factors. Also, of course, maybe how media and other influences are portraying mental illness and also treatment, particularly medication. And now the big one, I think, is stigma. Even though we have some quite a few advances in psychiatry and treatment options. There still is a stigma, and one study suggested that we really haven't had much of a dent in stigma even after 25 years of trying to work on these issues. There was a study, this is a national stigma study, this is out of the Academy Journal a few months ago, and what they did is a very interesting study, how adults perceive mental illness. And they interviewed over 1,000 adults, and they gave them two case examples of an ADHD kid and a depressed kid. And they were able to identify if this is a mental disorder and other factors about it. And they found that of these adults, about 58% of the people identified depression. They would say this kid is depressed. And then of those people, 69% of them identified that as a mental illness. Not that bad. But then on a lower scale, only 41% of adults identified ADHD. They said, oh, that kid must have ADHD. But of those, only 45% of them thought that was a mental illness. And even worse, even more concerning is 19% of them said that that's ADHD, but ADHD is not a mental illness. They rejected that label as a mental illness. And that's concerning. So in the family, the adults that we deal with, the non-medically trained or psychiatric trained people, may not identify the mental illnesses and also see them as illnesses requiring treatment. They went on to find that of those people that identified either depression or ADHD as a mental illness, they did pretty good. That 89% of those adults thought that depression could be treated, but only 75% thought that ADHD could be treated. And when they gave them options of what type of treatments would be effective, there's interesting results of this. So for instance, 75% thought that depression could be adequately treated by friends and family. 87% thought teachers could treat this or be a good option for treatment. General practitioners or family doctors, 88%. A good proportion, 95%, thought mental health providers. But on the lowest of that, maybe number 5, is psychiatrist. Would be a good treatment option for depression. So I think some of our parents have some preconceived ideas of what treatment options would be good for them. More importantly, though, is in terms of ADHD, of those adults that identified ADHD, thought it was a mental illness, when they thought of treatment options, again, friends and family, 70%, 88% of the time they thought a teacher could be adequately controlling ADHD symptoms, general practitioners, mental health providers, but the lowest rate would be psychiatrists, which is really quite concerning. Only 64% of people polled thought that a psychiatrist would be an appropriate treatment for ADHD. So I think our parents have already had some thoughts or preconceived notions about what we might do for their child. And more importantly, Dr. Guman brought it up earlier that this is a study just out in last month's Academy Journal. They surveyed over 10,000 kids, youth. This is teenagers, 13 to 18 years old. They found of those children, I didn't report on how many they thought they diagnosed with a mental disorder, but of those kids with a mental disorder, only 36% of them had ever received treatment, which is a very low rate, even despite what we've been trying to do in terms of helping with stigma and educating families and youth. Very few people that are out there, very few kids that are out there with mental illness are getting treatment. What was interesting then was paring this down. The highest rate is ADHD, but there's still only 59% of kids out there with ADHD, these adolescents, receive treatment for this. I know a lot of people somehow think that we're overdiagnosing it, but we're actually severely underdiagnosing ADHD still. The lowest rates were specific phobia and separation anxiety disorder. only 6 to 7% of kids. So that's really quite concerning. This isn't compliance, this is getting into treatment, but it seems like issues that are keeping people from treatment are also keeping them from continuing treatment and having them leave treatment prior to finishing the treatment. Any thoughts or comments about these two studies, about stigma in general? So I think, because I do think that we really do have to be aware of this issue about what parents are kind of coming to us with some preconceived ideas of how we can help the kids. So let me talk briefly about, may not be a very thorough discussion, because I wish there was more. There wasn't a lot on strategies to improve treatment, but I think we have some good options and some good ideas. And this is some factors I've noticed when I've been looking through the literature for some practical issues, particularly in medication with ADHD. Some factors that have been found is, one very practical issue is that long-acting medications have higher adherence rates, which is pretty typical, maybe intuitive, of having once-a-day medicine. Kids adhere to that better than having to take medicine two, three times a day, taking medicine to school, etc. And that makes some sense, and that's something I think we do have an advance now in terms of in the past when we had to give kids medicine several times a day. Interestingly, though, there was a study that showed that if you use continual medicine, rather than giving them breaks over the summer and maybe brief breaks, which I know a lot of people typically do. I do sometimes give a break of maybe 3 or 4 days a couple of times over the summer, but found that those kids had a lower adherence rate than the kids that take the medicine every day year-round. So it kind of gives me pause of how to work with that and how to give some break or maybe no break at all, and what's behind that. It seems like in my work, the kids that do that, they take a break over, maybe especially over the whole summer. It's really hard to convince them to get back on the medicine in the fall. They say, "Oh, I didn't get into trouble, I did okay," and it may be really hard for parents to convince the kids, "Oh, you need it for school." But I think that's something to consider about how to work with families and kids being continual and consistent with medicine. And also, we have to be quite aware of what the most common reason why kids particularly stop medicine for ADHD, like that the first mother that I talked about in that interview, that medication side effects are a very common issue. Even though the other medicines may have just as many side effects, but it seems like people are more in tune or more concerned about side effects to ADHD medicines. But I do think that we have to really manage the side effects well and really work with families and understand the side effects, prepare them for the side effects, and also I'd be able to identify target symptoms and give the parents a good idea of what the medicine will do and what it won't do. And also the final thing is really I'd be able to identify and notice and treat comorbid disorders. For instance, that disorder that studies showing kids with oppositional defiant disorder have higher dropout rates. You really have to be able to identify that issue and work with them in that way. Certainly kids that have ongoing substance abuse will have much higher dropout rates, and so we have to be aware of that and certainly screen for a lot of other disorders. Anxiety disorder may be another comorbid factor that can cause kids to drop out more often. So I think that's important to discuss with kids. Also, educating parents. We've spent a lot of time educating, giving them resources, handouts, information from websites. It does seem as if giving more expert opinions or expert advice works a bit better. I mean, we can tell them and describe things, but it is helpful for parents to see this on print or something that's an authority figure to get information about particularly medication or treatment or diagnoses and other options. I think the Academy, American Academy of Child Psychiatry, has some good websites and good information for parents. Also, in terms of incorporating other people in the family, because again, we have to acknowledge that families are getting a lot of other influences or perceptions, incorporating friends, families, PCP, sometimes teachers, in terms of the treatment and compliance for all disorders. ADHD is again the commonest one, but incorporating other people in terms of treatment. And also, this is a harder one to do, is how to advise or incorporate or facilitate treatment for parents' mental illness, whether it's depression. A common one I see is ADHD, and how to get them into treatment, advise them of where to go and how to get their phone numbers or whatever else you can do to help them get their own treatment. Any other thoughts you guys had about other things to do with parents that's maybe worked or hasn't worked? Yeah, Dr. Guman.
I was thinking about the side effects of treatment as well as information on the media that parents are privy to, as well as the death and the Ritalin.death.com or whatever. So I actually address it very head-on. I talk to parents and before prescribing medication that I know you're familiar with this, and I know there's a lot of media out there and some bad media, as well as that they actually haven't deaths with Ritalin, so that they don't end up finding out and then worrying about it and not being compliant. And that seems to work pretty well.
Yeah, that's a good point in terms of side effects and preparing parents, giving them information of things that they will have heard of in the media about cardiac side effects with medication, other side effects, and being quite upfront about what sort of side effects can happen. Giving handouts about medicines and frequency of side effects, etc., I think is quite helpful. Good point. And other issues that come up, and this is also in terms of literature review of time to explore options. Interestingly, there's one study that found that this is hard to incorporate in our practice, but a study that found that if a parent was given, like if the child came in, they get given a diagnosis of ADHD, but a parent was, instead of given a prescription, they were given information and education about the disorder and about medication, and then they came back, they thought about it for a while, they came back, and then they started on a medication. They had much higher adherence rates if they did that, rather than giving a prescription on the first appointment. They had a much lower adherence rate, which is a very interesting topic, which is hard to do that in our practice, especially with maybe needing to do things maybe quicker than we like. But it does seem like giving time to families to incorporate this information, to accept information, research what they do, or research what we're suggesting for the child, may pay off in the long run. Okay. Again, be available for questions and answers when they come back, when they're asking issues, calling, maybe also giving other information via websites so they can look into this more often. But also acknowledging their fears. And I think that's an important issue, acknowledging that they've heard some horror stories about various treatments and medication, and understanding that and being pretty upfront about that too. I know you've heard these things. Do you want to ask me about them? And parents often bring up all sorts of things we may never have considered about side effects in terms of effects on the liver, kidneys, whatever, and we have to be helpful in terms of understanding their fears, because they've heard quite a few bad things. And in terms of acknowledging the fears, interestingly, Russell Barkley, he's a frequent, very large researcher on ADHD. He suggests actually, rather than educating, you have to educate too, but also, counteracting with some other issues about what the risk is of not treating. And whether that's always helpful or not, it's hard for me to tell, but suggesting that not treating can be as maybe worse or bad, just as bad as treating in terms of other bad effects of ADHD, certainly school dropout rate, substance abuse, teen pregnancy, etc. You suggest that, and that it brings up an issue about fear in general. If educating sometimes doesn't seem to overcome the fears that parents may have. And an interesting topic, a somewhat side topic, there's been a lot of talk about the studies has been kind of disqualified, but the study that found that autism was being caused by vaccinations. And there's been a lot of studies showing that was disproven, that vaccinations do not cause autism. But still, there was a poll that found that still 25% of parents still believe that autism can be caused by vaccinations. So it seems as if educating doesn't always counteract the fear that they may have initially of what they heard, what may happen. And one person I heard talk suggests that maybe we may have to, like Russell Barkley is suggesting, we may have to counteract that fear by a newer fear or maybe a bigger fear. If you don't vaccinate your kid, they may die from various disorders or diseases that had been treated in the past. So whether we have to kind of then overcome a fear with a new fear, it's kind of hard to tell, but that seems to be one avenue. And also, maybe some other more strategies, or these aren't maybe some practical strategies, but some things I've seen in the literature about how to deal with compliance issues. This is maybe more thorough, or maybe more descriptive term that I just described in terms of mental health guidelines, working with the clarifying beliefs of the parents, understanding their conceptions, perceptions. Address misconceptions, support exploration of alternative treatment, but only, I guess, only unless those wouldn't be contraindicated, if they wouldn't be harmful for the patient to have other alternative treatments. Recognize also, as I said, the larger family context, understanding that other influences, other parents, other families that are giving advice to these parents. Allow time to change attitudes. I think that's kind of what I said earlier. Allow time, having parents understanding that these are options, and then recommend some treatment after they've given some time to understanding this. Yeah, Dr. Grimmer.
A long time. And many times what I also do, especially because I treat younger kids, I ask, and especially if those parents had a good relationship with the PCP. And many times, when they bring up concerns, and before I even write the prescription, I suggest to them that they consult with the PCP to make sure that their questions are answered not just by me, but also by the PCP. And if they have fears that this side effect may happen or what might happen, that the PCP can reassure them also. Many times, PCP support also helps.
That's a good point in terms of incorporating PCPs and having the parents talk with them about your recommendations and to allay some of the fears about medication. It does seem like, I know PCPs would like us to maybe communicate with them so that they know what we're recommending also. Good point. Yeah, sure.
We need to clarify the expectations that parents have, because more than a couple of times we have seen in our clinic, parents wait for like 2 months, 3 months to get an appointment with the psychiatrist, and when they come to the appointment, it's like, oh, I come to this big person and now fix my kid. But we kind of like really discuss the options, and it's going to take time, so it's going to be longer therapy, and so I think that's one of the reasons also. If we don't clarify upfront, I think the dropout rate is also higher.
Yeah, that's a very good point in terms of clarifying and understanding maybe how long the family has been waiting for the appointment, and also in terms of there is quite a delay from the onset of symptoms to treatment. It's very long for mental illness, up to maybe some studies suggest that some disorders don't get treated until 9 years after the onset of symptoms. But for kids, we often see kids that maybe have had symptoms since they were started grade school and kindergarten. Now we're seeing them when they're 10 years old. So it's been having problems for 5 years, and the parents have tried a lot of other things. They've tried advice, they've tried some behavioral techniques, and nothing's worked. So they really are kind of coming with a lot of expectations about helping their child, and you do have to then kind of focus on, the whole picture and focus on the things you can do. A lot of times, unfortunately, we have to, especially with treatment of ADHD, we have to start on a low dose and work up. So parents often find that it's not working initially. So we have to make sure that they can communicate with us, see and make any changes relatively quickly, so we can get the ball rolling rather than waiting months and months and months. But that's a very good point. Mm-hmm. And also in this study, they described other issues about, having often access, like I said before, having ways to contact you or contact other people in the treatment team to make some changes or to offer medications or changes that are required. Especially in a very busy practice, you have to have some way to have the family contact you to see what's happening, changing or managing side effects quicker rather than waiting for 2 months or a month before you can see them again. And then you may have to be able to then, you're going to working with the family and then guide them kind of gradually towards what they would consider best practice parameters. You may not start with the optimal treatment, but you're going to work with them and guiding them that way towards something that would be most effective. And also a more theoretical approach is some have been looking at treating, looking at ADHD as maybe other mental disorders too. ADHD is a chronic mental disorder, chronic medical disorder, much like treatment for asthma and diabetes. And I know pediatricians are working on care models that they can incorporate treatment for those other medical disorders, but seeing also ADHD and other mental disorders in a more of a chronic care model. And in this model, they describe a lot of terms, a lot of factors in this model that seem to be a bit hard to incorporate, but I think the issues are important to understand in terms of decision support, in terms of helping the parents decide in terms of diagnosis and treatment, how you're going to what system of delivery you're going to have, clinical information systems. I think that's more in terms of information for the family, and helping supporting the family and also the child themselves, and other community resources. And I think that's at times worthwhile. It's in terms of other resources in the family. I often give parents like the information for CHAD, which is the national support group for ADHD for both kids and adults with ADHD. And there's quite a few parent support groups around town that they can go and talk about their kid and their issues with ADHD. So then having community resources is helpful as well. In healthcare organizations, I think that's maybe down the line, but having a whole healthcare organization that works in kind of managing this kid's behavior and symptoms over a long period of time. And last, I want to talk about this other study. I think that was interesting. This is actually written by a person here in our College of Nursing who decided working with youth for ADHD using what's called a Roy adaptation model. I believe it's a model in terms of looking at different facets of each person's life and trying to optimize, getting them to the optimal kind of point in these different facets. And found that what helped in terms of getting kids compliant, particularly again kids with ADHD, is working on these different facets and getting them to this optimal point. One is looking at the physiological facet of the person, seeing that when it works best is when a kid sees, well, the meds are a hassle, but they help, they work. which means that kids understand, we kind of acknowledge with the kid, it's a hassle to take this medicine every day. There are some side effects we have to kind of work around, but it helps you get through the day better. And I think that's a way to look at it, and maybe the optimal point for kids that we work with. Role functioning is another facet, and try to have a kid see, it helps me do better at school. Their facet of their life in terms of school as a student, I do better in school. The term that you use is the interdependence, meaning how they interact with other people, particularly with the family. The kind of optimal, what you're kind of shooting for is when the kids say, things are better with my family when I'm on my medicine, and my friends don't know, meaning that my friends don't know I'm taking medicine. It's kind of a separate issue for the child. And another facet of the self-concept or group identity, being able to see I'm just another kid, I'm just a normal teenager, almost as if, again, brought this up about the label. We may want to be able to actually stay away from the label of ADHD at times, and this medicine helps you, get through the day. It seems like the label of ADHD does cause a lot of issues on its own, so maybe kind of focusing on how they're like other kids that just take some medicine every day. But I think that's kind of the optimal, what you're kind of shooting for these kids. And lastly, I want to talk more about this other topic of, this is a researcher out of Stanford that described what we often see is that pharmacotherapy is often a psychotherapeutic intervention. And we have to use psychotherapy interventions, psychotherapeutic aspects in dealing with kids for medication management. You still have to work deeply with the therapeutic alliance, understanding the kids and also the families, but understanding the kids' issues, what he sees as not going right for him. They're getting into trouble, you're getting into timeouts, you're sent to your room and such, and kind of understanding that therapeutic alliance with the kid. And also understanding the broader implications psychological for a kid with medication. Does it mean I'm sick, I'm crazy, whatever they may use, in understanding those issues. So we're kind of working with that in terms of that psychological aspect. And also developmental issues. I mean, certainly younger kids will have a harder time understanding at times what it is. I know a lot of parents try to tell the kid that it's a vitamin that they take every morning. But I think understanding the development, and maybe an older kid, an older teenager may have many issues about body and body integrity and side effects, especially at various ages. So understanding those issues as well for kids and compliance achievement, particularly medication. And the harder one may be in terms of being able to deal with the alliance, both of the parents and the kids, because there's a lot of situations where the parents are more wanting to have the kid on medication, particularly, and the kid doesn't like it, and how to kind of have that alliance, so kind of working with the kid, and having the kid maybe talk to you directly rather than being angry with the parents about giving the medicine every day. Talk to me about it. What's it like for you? I want to understand what it's like for you to be on medicine. And of course, that also works in having kids in treatment and psychotherapy of these alliances and understanding these developmental issues. Anyone think about other issues in terms of psychotherapeutic aspects of medication? I'm sure there's quite a few others. Yeah, Dr. Goodman. Yeah. Okay.
With teenagers, like a lot of times parents, they want them to take care of their medicine themselves. And some of the teenagers, they like to do that too. But then we have, a lot of them are kind of dependent, and they There's maybe the only interaction they're having. Like, when people get sick, sometimes they want someone else to take care of them or remind them. So sometimes that doesn't work. When parents say, you just take care of medicine and you give them, they end up not taking medicine. And the medicine may be sitting on the desk or something. So sometimes it's good to have that kind of discussion between the parents and the child, who's going to supervise, who's going to, do they want parents to remind them or give them medicine, or they're going to be more responsible or not. So that can be a big factor.
Yeah, that's a very good point about how to supervise or how to have the child be either independent on medicine or be completely dependent with the parent for medication. And that is a tough one, especially for the older kids, the teenagers, in terms of how much independence, but therefore how then the parents monitor whether the kid is taking medicine or not. And I often have to tell parents and tell the kid that it's nothing against them, but I know kids with ADHD are often forgetful, so having the parents watch them take the medicine to make sure that they're doing okay. Also for me to be okay and be sure that they're taking medicine. I don't want to increase your medicine just because I thought you're taking it but you're not. Those sort of things. It's a very common issue. Another similar issue comes up much more often now, especially with our working families, when the parents have to leave home and the kids have to get themselves to school in the morning, and whether they're going to take the medicine or not, or if the older child in the family can supervise the medicine. That comes up often, and how to incorporate that, how to help kids and families be more compliant with medicine. Often we kind of recommend having those pill reminders on the Sunday through Saturday, pill reminders so parents can see, well, I can see now he took his medicine this morning. Usually, they could have thrown it out or spit it out, but usually they can monitor how well they're compliant with medicine if you do that. But there are many other factors that come up with kids like this. Unfortunately, some kids have to take medicine at school so that they can monitor it closely. We prefer not to, because then they get into other issues about compliance if they have to take it at school. But sometimes that's the only option. Yeah, Peter.
Yes, kids from broken families. That's a big one. When they're going back and forth, trying to get those parents on the same page can be difficult too.
Yeah.
And that sometimes maybe they're not taking it one place and taking it the other. It could be almost like one parent gets back to the parent and not taking care of the kid, So that makes it very complex.
Yeah, that's a very good point in terms of the divorced families, when one parent will give the medicine, the other parent won't, and how do you deal with that, and how you also have to make sure that it's safe enough for the kid to not be on the medicine over the weekend. That does happen quite a bit. As I said, in terms of causative factors, fathers tend to be less compliant with medicine and less able to identify the disorder in the kid. And sometimes you just have to work with that. Unfortunately, we have a lot of kids that are only on medicine during the week because the one parent doesn't comply with medicine. But you want to do that in a safe way. You wouldn't want them to be on the medicine that they have withdrawal effects every weekend, and that sort of thing. We try our best with that, and I know it's often a difficult situation. Yeah. Any other thoughts about this, about working with kids and psychological issues? Yeah, Dr. Gruman?
Area of support is child therapists, other providers, and they can be very helpful and supportive sometimes in adherence to medication and appointments. If they have questions or side effects, they can. So working collaboratively with therapists, I think is very important.
Yeah, that's a good point in terms of working with a therapist in terms of compliance and I think it's a good medium to have someone that isn't directly related to the medications. The parent can then report these problems or concerns, and they can get back to you that's a pretty common issue, and I think that's something we should be open to when other providers are have concerns about the treatment and medication. I'm just going to finish up with just maybe an overview of what I see as of strategies in terms of, again, acknowledging. I think that's probably the biggest issue that I see is acknowledging that the parents have all these concerns and thoughts. Often parents have waited many years to get treatment or to even consider this. And we have to acknowledge that. They've come with a lot of preconceived ideas. They've heard a lot of bad stories. And we have to acknowledge that they have the fears and they have these concerns and how to allay some of these fears. In terms of educating, I also didn't touch on it much, but how to remove some of the barriers in terms of getting into treatment. It may be other issues that we're not in control of in terms of insurance coverage, and also just the availability of child psychiatrists or child mental health workers. Something that's we're trying to make a dent on, but that's something that having some barriers, removing some things to keep getting kids into treatment, but also staying into treatment. And also the big one of reducing stigma, so families can feel comfortable about treatment. Because I see that, in terms of my day-to-day work, parents don't seem to have as much issue. If a kid has asthma, they go in, they see the doctor almost right away. They get treatment. They don't seem to ask questions about the medicine that they give for asthma, but they ask a lot of questions for us in terms of our disorder, our mental disorders, our diagnoses, and also our treatments. For instance, when I looked over the literature, there's a lot of articles also on poor compliance with medical treatments, but most of the compliance rates, most reports show that kids didn't take medicine because they forgot. Not because they had side effects or didn't like it or something, but the kids and families forgot to take the medicine. And it's much different than what we see in terms of mental health care. So any other thoughts or comments? Yeah.
Maybe last 20 years or so, there has been more emphasis on home-based or school-based treatment, which I think, if they can't come to us, we go to them. That's the philosophy. And I think it does help. I think maybe another 20-30% of people, kids or the family become compliant, especially if you're dealing with more, poor families or disorganized families. So, I think we need to develop more. I think in the adult psychiatry, they have been doing these ACT teams and, going in the teams, going in the community, even psychiatrists going in the home or schools. So I think that can improve with the adult psychiatry too.
That's a good point in terms of having more maybe home-based or school-based. I know there is a large, some push and some programs that encourage school-based treatment. It's because the kids do spend much of their day every day at school. How well that functions, it's hard at times because you still have to pull the families, the parents, into the school to really work with them. It makes some sense. It's sometimes hard to do. And home-based, I know in clinics, the community clinics, they do some home-based treatment, and I think that's effective. We do cut down some of the barriers on kids, parents that have child care problems or school or work-related problems that they can't get to appointments, transportation, other things that can be a barrier to go to them. That does make some sense. Sometimes it's hard to incorporate, but I think that's a worthwhile option. Any other comments or thoughts? Okay. Well, thank you very much.